Our last speaker is Dr. John Hunter. He's a professor and chair of surgery at OHSU in Portland. He's also a member of the steering committee of the ACS Transitions to Practice program, and he's going to speak to us about that program.
So I'm here representing the American College of Surgeons. My disclaimer is I don't have a TTP program at the current time, but we're starting one. So I've really gone through the thought process of this. I'm equally representing the American Board of Surgery. I've been on the board for 11 years as an advisory council from the SSAT to GI surgery. And in a year and a half, I'll be the 2 years, a year and a couple of months, I'll be the board director or the chair of the board. And so I'm very interested, as are we on the board, in residency redesign. What is the role of the fellowship? When do fellowships occur? How do they occur? So this is a really good dialogue, and I'm hoping I can get these slides to take to the board retreat in June, because I think there's a lot of great data here. So anyway, this is a bridged presentation. I'll try to move through it fairly quickly. I think the last steering committee meeting that I'm part of with the TTP programs, we likened where we stood today as primordial soup. We're in an evolutionary stage, and I think that the redesigns in residency training will make these programs much more popular than they are for reasons that I'll try to elaborate on. So these came out of an issue identification exercise at the College of Surgeons, understanding the growing concern about preparedness of residents for independent practice, the disconnect between perceptions of surgeons entering independent surgical practice and those accepting the individuals. Said another way, the Matar study and the study that I think Ezra just alluded to suggested that many of the program directors felt that residents coming out were really not prepared. Board of Surgery did a survey of residents leaving their residency and found the opposite, that they were actually quite confident. They felt they were prepared. So there's a real discrepancy in that perception. And the fewer meaningful experiences of residents in critical domains due to major changes in residency training, especially as fellowships have developed, and a lot of what was taught in general surgery is now being taught to advanced trainees. The preparedness of those entering practice was one of the 5 top issues in the 2012 ACS Board of Governors survey. I think most of you know that the pass rates on the ABS exam, certifying exam, have fallen over the last 10 years. We actually have changed the exam a little bit. I don't think we've dumbed it down, but we've changed it, and I think that number is falling a little bit more down towards 20% failure rate. Surveys of residents, again, show 25% do not feel preparedness for broad-based practice. So this led to a conference on a transition to practice that was convened in 2012, plenary session, small groups, 75 individuals from all the constituent organizations, RRC, program directors, professional societies, 12 surgical specialties, and also included the American Hospital Association, Joint Commission, U.S. military, all interested in the quality of the trainees that they were getting into their hospitals. The result of this session was a steering committee was created to develop the TTP program. The framework was created, the training model was outlined, and principles of accreditation were defined. So here is the steering committee. Many of these names you will recognize, and Frank Lewis doesn't really participate much. Dave is really mostly Mark Malangoni and myself from the Board of Surgery who are active in this group. The elements, really the number one word on this slide, and the number one element of the TTP program is autonomy. The goal here is to take someone who's finished a general surgery residency, put them in an autonomous experience with a mentor, but one in which they're protected to a certain extent because of the mentorship experience, and they're not committed to that practice for their whole career or even a short part of their career. So that it's really an audition in many respects for the individual of that practice and for the practice of the individual. The second word here is flexibility, to meet the needs of the trainees, and it's designed to have significant experience with broad-based general surgeons, and a focus on clinical problems encountered in clinical practice. Additionally, the residents identified that they wanted to learn some practice management, and there's ongoing evaluation of the associates. They're not called fellows because that was kind of felt that this was different from a fellowship, and in fact, in some ways, it is different, but in many ways, it's similar. The services are billable, and there's a balance of the flexibility with the rigor of a curriculum. And this last bullet's important because all fellowships must not interfere with the education of general surgery residents, but this really is a general surgery fellowship. It is recognizes general surgery as a specialty, and it's a general surgery fellowship. For that reason, most of us think these are really best suited to be outside of the academic or medical center, outside of the confines of the general surgery training program. So what isn't it? It's not exclusively for rural surgeons, although I think our program that we're putting together in Oregon will be a rural program. It is a requirement for general surgery. It's not a requirement for general surgery practice. It's not rules-oriented. And they really point out that it's not a remediation program for people who can't make it or can't get a job. 4 key areas are looked at in accreditation: admin, curriculum, assessment, the usual things. So this started in 2013 with 2 institutions, 13 institutions, 2014, 2015, now 18 institutions approved, and 80 more that have expressed interest, and we're one of them. Now, this is an interesting sort of disconnect, is that the number of places starting fellowships is on the rise. The number of people interested in them is really pretty flat. And so this is a thing we'll have to watch to see if the demand actually does go up. Obviously, if the demand doesn't go up, these things will wither on the vine. So where are the programs now? Again, I'm not going to read all this list, but you can see that a lot of them are not in, they're not at I don't think I see Duke there. I don't, see major medical centers as Anne Arundel as opposed to University of Maryland. And yet you do see some, University of Louisville's there. There are some programs that are in big academic medical centers. But I think the trend is to move out of that setting into the Geisingers and Gunderson Health Systems and places like that. Motivations, why do it? Certainly the individuals who are doing them have been queried. They desire more broad-based experience. There are certain recent graduates who didn't find a job that they liked. We had a person who I thought would be perfect as our first TTP fellow, but she found a job that she really liked, and so took that. So again, the demand for general surgeons is so high that it may influence the number who want to do these fellowships. Practicing surgeons desiring re-entry has been a reason to do it. The program impact, so is to aid those with fundamental training who need additional mentoring, who need additional confidence. Again, as a chair, I can kind of identify who those people are, and I honestly think that some of these people going out into their first job in general surgery really should be going into these programs, but I can't force it. I can only counsel them. Again, increasing number of general surgeons are needed in the face of a diminishing workforce. So you can do the arithmetic there. Better increase patient safety through better training and better coverage. So what have we learned from the feedback? The TTP program provided experience not always available in residency and increased their confidence, again, as expected, offered flexibility to tailor experience, covered critical practice management skills that weren't learned in residency, and delivered valuable expertise by working with senior surgeon mentors. So that's kind of the brief fly-through of what the TTP is designed to be. Again, the fellowships are on increasing in number. We will see what the interest is as time goes on. Thank you very much.